Hey everyone, welcome back to the channel. I am so glad you are here because today we are tackling one of my absolute favorite topics in pharmacology, calcium channel blockers. Now I know drug classes can feel intimidating, but stick with me because by the end of this video you are going to walk away with these locked into memory. We are going to use mnemonics, we are going to keep it simple, and we are going to make it stick. I am Professor Shaibu Orichabello, and this whole lesson is built for exam recall. So grab a coffee, get comfortable, and let us dive in. Alright, before we get into the good stuff, let me give you the roadmap for today. We have 6 big themes to cover. First, the mechanism, how these drugs actually work. Then the 2 classes, and trust me, splitting them into 2 is the secret to everything. Then clinical uses, side effects, and toxicity. And finally, my favorite, a consolidated mnemonic cheat sheet you can screenshot. Do not worry about memorizing the order, just follow along. Each piece builds on the last. Ready? Let us go. Okay, here is the big picture, and honestly, if you only remember one thing from this video, make it this. Calcium channel blockers block L-type calcium channels. That is it. When you block those channels, less calcium gets into the cell, and here is my little mantra: less calcium, less squeeze. Less squeeze in the blood vessels means they relax and widen, that is vasodilation, and less squeeze in the heart means it beats slower and softer. Say it with me one more time: less calcium, less squeeze. Beautiful. Everything else flows from this. Now let us walk through the mechanism step by step, nice and slow, because this is where students sometimes trip up. Step 1, the drug blocks the channel. Step 2, intracellular calcium falls. Step 3, the blood vessels relax. Step 4, the heart slows and pumps less forcefully. 4 simple steps, all linked together. And here is a classic exam trap. I want to protect you from the serum calcium level in the blood does not change. We are talking about calcium inside the cell, not in the bloodstream. Do not let that question catch you out. This right here is the most important slide in the entire lesson, so lean in. There are 2 families of calcium channel blockers, and once you split them, everything becomes easy. Family 1, the dihydropyridines, they love the blood vessels, the pipes. Family 2, the non-dihydropyridines, and there are only 2 of them, verapamil and diltiazem. They love the heart, the pump. Pipes versus pump. That is the whole game. Whenever you get stuck later, just ask yourself, is this a pipe drug or a pump drug? Everything else falls into place from there. Let us meet the pipe family, the dihydropyridines, and I have got a mnemonic that makes these effortless. They all end in dipine, so just remember dipine equals pipe. Amlodipine, nifedipine, nicardipine, clividipine, nimodipine, hear that ending. Dipine, dipine, dipine. They dilate the pipes, your blood vessels. So anytime you see a drug ending in dipine on your exam, your brain should instantly shout pipe vasodilator. Easy, right? I told you the 2 family split would pay off. Now the pump family. Here is the good news: there are only 2 members to memorize, verapamil and diltiazem. My little trick: 5 and D are not dipine. They do not end in dipine, so they are not pipe drugs, they are pump drugs. Verapamil is the most cardiac of all. It hits the heart hardest, and here is a quirky one students love. Verapamil hits the ventricle and causes constipation. Both 5 and D are also class 4 antiarrhythmics, meaning we use them to control heart rate. 2 drugs, that is all. You have got this. Okay, take a breath, because this table pulls it all together, and I genuinely love a good comparison table. On the left, the pipe drugs, the dihydropyridines. On the right, the pump drugs. Look across the rows, where they act, what happens to heart rate, what we use them for, the side effects and the examples. Notice how the pipes work on vessels and the pump drugs work on the heart, are mirror images of each other. If you can recreate this table from memory, honestly, you have basically mastered the topic. Pause the video and try to fill it in yourself. So where do we actually use these drugs in real patients? This is the fun part, where the pharmacology meets the bedside. We use calcium channel blockers for hypertension, for angina, for certain arrhythmias, for Raynaud's phenomenon, for cerebral vasospasm with nimodipine, and even, get this, for preventing cluster headaches with verapamil. Notice the pattern again. The pipe drugs handle the pressure and vessel problems. The pump drugs handle the rhythm problems. Match the use to the mechanism and you will never have to rote memorize a single one. Now these next few are the special agents. The VIPs and examiners absolutely love them, so let us give them some extra love. Nimodipine. Here is my mnemonic: nimodipine for the mind. It is the one we reach for in subarachnoid hemorrhage to protect the brain. Nicodipine and clevidipine, those are your 4 drips for hypertensive emergencies. And verapamil shows up again for SVT and cluster headaches. These specific pairings are pure exam gold, so circle them, so star them, screenshot them. When you see the buzzword, you will know the drug. Time for side effects, and here is the beautiful thing. You do not even have to memorize them. You can reason them out. The pipe drugs dilate vessels, so their side effects are just vasodilation taken too far. My mnemonic: dilated pipes leak. You get peripheral edema, that swelling around the ankles, and that is the single most tested side effect, so remember it. Then flushing, headache, dizziness, a little reflex tachycardia as the heart speeds up to compensate, and gingival hyperplasia, overgrown gums. See, it all just flows from the mechanism. And now the pump drugs. Same logic, just flipped. If these drugs slow and weaken the heart, then overdoing it, it gives you cardiac side effects. So we see bradycardia, a dangerously slow heart, AV block, where the electrical signal gets stuck, and worsened heart failure because we are dialing down the squeeze too much. And do not forget our old verapamil causing constipation, verapamil ventricle constipation. Notice the pattern across both slides. Side effects are vascular, pump side effects are cardiac. The mechanism tells you everything. Alright, let us talk about when not to use these, because knowing the contraindications can literally save a patient's life. The pump drugs, verapamil, and diltiazem. Avoid them in heart failure with reduced ejection fraction, in bradycardia or AV block, and be really careful combining them with beta blockers because both slow the heart and together they can stop it. For the pipe drugs, avoid short-acting nifedipine in acute coronary syndrome and keep an eye on those CYP3A4 drug interactions. These are the safety rails, so commit them to memory. Now toxicity, this is high yield and honestly kind of dramatic, so pay close attention. Calcium channel blocker overdose gives you three things: bradycardia, hypotension, and here is the surprising one: hyperglycemia, high blood sugar, my mnemonic for the slow heart, the Brady Bunch. And what is the antidote of choice? High-dose insulin euglycemia therapy, we call it HIET. I know insulin for a heart drug overdose sounds bizarre, but it works beautifully. Bradycardia, hypertension, hyperglycemia, and HIET to the rescue. Lock it in. This is the slide that separates the good students from the great ones, the overdose differential. Calcium channel blocker versus beta blocker overdose. They look like twins at first, true, both give bradycardia, hypotension and AV block. So how do you tell them apart? Here is your key. Calcium channel blockers cause high blood sugar, hypoglycemia, and the patient often stays awake and alert. Beta blockers do the opposite. They cause low blood sugar, hypoglycemia, plus CNS depression, seizures, or white QRS, and bronchospasm, especially the lipophilic ones like propranolol. For treatment, calcium is your first move for the CCB glucagon for the beta blocker, and that wonderful high-dose insulin therapy helps both. Sugar up versus sugar down, that is your tell. Brilliant exam discriminator. And here it is, the slide you have been waiting for, my favorite, the mnemonic cheat sheet. Everything we have built today, all in one place. Dipine equals pipe 5 and D are not DP. Less calcium, less squeeze, dilated pipes leak. Verapamil ventricle constipation. Nimodipine for the mind, the Brady Bunch. This is the slide to screenshot, to print, to stick on your wall the night before the exam. Pause right here and read through each one out loud. Trust me, saying them out loud makes them stick so much better than just reading silently. Now let me share some clinical pearls. These are the little exam traps that I have watched catch out so many bright students, and I do not want that to be you. 1. Dihydropyridines can cause reflex tachycardia, the heart speeding up to compensate. 2. That ankle edema does not respond to diuretics, so do not be fooled into adding one. 3. Never casually combine a drug with a beta blocker. 4. Hyperglycemia plus an alert patient screams calcium channel blocker overdose. 5. Nimodipine is for the brain. And 6. Watch those CYP3A4 interactions. These 6 pearls are worth real marks, so tuck them away. Okay, pop quiz time. And do not worry, this is the fun kind of quiz, the kind that builds your confidence. I am going to ask, and I want you to answer out loud before I reveal it. Deal. Which drug class is first line for certain patients? Which side effect causes ankle swelling? Which drug gives you constipation? And what is the antidote for the overdose? Go ahead, pause and answer each one. Got them. If you did, give yourself a pat on the back, because that means today's lesson truly landed. And if you missed a couple, no stress. Just scroll back up to that cheat sheet. And that brings us home, the 4 big takeaways to carry with you. 1. There are 2 families, pipes and pump. Split them and you have one half the battle. 2. Match the use to the mechanism. Do not just memorize, understand. 3. The side effects always follow the site. Vascular for pipes, cardiac for pump. And 4. Respect the overdose. Remember the Brady Bunch and reach for high dose insulin therapy. That is calcium channel blockers. Done. If this helped you, give it a like, subscribe for more, and drop your favorite mnemonic in the comments. You worked hard today. I am proud of you, and I will see you in the next one. Take care.